Good evening and welcome. I'm Nora Kane. I'm the director of the Stanford Health Library, and it's my pleasure to welcome you tonight to a wonderful talk that I know a lot of you are very interested in, a subject that affects all of us, about optimizing our sleep and recognizing serious sleep problems. It's my pleasure to welcome as our speaker tonight, Dr. Clete Kushida. Dr. Kushida is a neurologist who specializes in the diagnosis and management of sleep-related breathing disorders. He is a neurobiologist, a professor in the Department of Psychiatry and Behavioral Sciences at Stanford. Dr. Kushida is division chief and medical director of the Stanford Sleep Medicine and the director of the Stanford Center for Human Sleep Research. So I think you know that you're going to be in good hands tonight with this subject. And without very much more, I'm just going to say we will be taking questions as you can enter them into the chat box. And after Dr. Kushida is finished giving his lecture, we will direct the questions to him. And we'll take as many as we can before we hit the hour. So thank you very much and welcome, Dr. Kushida.
Thank you. And good evening, everyone. What I thought I'd do first is just talk a little bit about our sleep medicine service. As some of you might know, we're the first sleep clinic ever in the world, and it was started about 50 years ago by the late Dr. Williams Dement and Christian Guilleminault, as well as Dr. Vince Sarconi. And this just gives a snapshot of our sleep medicine service. We see about 15,000 patients per year in clinic visits and close to about 5,000 sleep studies. But we have about 17 faculty members with diverse expertise in various different sleep disorders, as well as 3 nurse practitioners and 8 clinical fellows per year. And as you can see, we have a lot of capacity for testing. We have 18 bedrooms and 20 home sleep testing devices, as well as 21 sleep technologists who run these studies around the clock, as well as over 15 clinical research studies that are done at any one time. I just want to show a little bit about what we've done, for the pandemic. So starting on March 6th, we started converting to video visits, and then we paused our sleep studies on March 15th, and we resumed our in-laboratory sleep studies on June 8th. We resumed our home sleep studies on July 15th, and we're planning on resuming our in-laboratory adjustments of our CPAP devices for patients starting on September 30th. So with that quick background, what I'm going to focus on are 3 main topics. First is the need for sleep, and then cover the 2 main sleep disorders of the close to 90 different sleep disorders. And one of them is a disorder of excessive sleepiness, which is obstructive sleep apnea, and the other is a disorder of insufficient sleep or chronic insomnia. So first, in terms of the need for sleep, I just want to talk a little bit about the prevalence of sleepiness. It's estimated that over 1/3 of the population suffers from sleep loss, and this includes 1/3 of young adults secondary to chronic partial sleep deprivation, about 7% of adults secondary to sleep disorders, and about 2% of adults secondary to shift work scheduling. And we know that about 1/3 of adults sleep less than 6.5 hours during the work week, and also that approximately 1/3 of normal adults fall asleep in less than or equal to 5 minutes. Now, we know this because what we do is we have this test during the daytime. It's called the multiple sleep latency test, where we have 5 scheduled naps throughout the daytime that start at 9 o'clock. So it goes at 9, 11, 1, 3, and 5 p.m. Each nap lasts about 20 minutes, and we see how long it takes a person to fall asleep. If they sleep less than 8 minutes, that's averaged over those 5 naps, that's considered excessive daytime sleepiness. And less than 5 minutes is considered pathologic daytime sleepiness. And you can see that there's repercussions for that, because when total sleep times in normal young adults are reduced just by 1 to 1.5 hours for just one night, you get decreases up to 1/3 in objective alertness the next day. So just by one night of partial sleep deprivation, you can have profound effects the next day. So just a little bit about sleep stages. So there's 2 main states of sleep. It's non-REM sleep and REM sleep. REM sleep stands for rapid eye movement sleep. And non-REM sleep is divided into 3 stages. It's N1, N2, and N3. As the numbers increase, it gets to deeper sleep, meaning that the person is harder to wake up during sleep. And this is a newer classification. Before it used to be called 1, 2, 3, and 4, but 3 and 4 got wrapped up into N3. Now, REM sleep is a period of cardiorespiratory instability. What that means is that's when the heart rate becomes irregular and the breathing becomes rather shallow and irregular. It's also the time when about 90% of the dreams occur. And the REM sleep, it lasts about 10 to 25% of total sleep time, and you have about 3 to 6 REM periods throughout the night. And each non-REM sleep cycle is about 60 to 90 minutes. And one other thing is that the REM sleep periods tend to increase in intensity and duration as the night goes on. So this shows what happens during aging. You can see that for a neonate, they can sleep about 16 to 18 hours, and about 50% of their sleep is REM sleep. That's why it's thought to be responsible for brain maturation. And as one gets older, you start not only decreasing in total sleep time, but also decreasing in both REM sleep as well as non-REM sleep. And also what happens is as you get older, that you get more frequent awakenings during the night, either spontaneous awakenings or awakenings caused by medical and sleep disorders. And in addition, you also get a corresponding increase in daytime sleepiness. And it also takes you, in most people, it takes longer to fall asleep. And as I mentioned, more frequent awakenings. Now, one frequent question that we always get asked is, how much sleep, does one need? Well, this is our consensus statement by the American Academy of Sleep Medicine. And basically what happened was they brought a group of us together in a room and locked the doors for the entire weekend. So we were pretty much confined in this one hotel. And then the idea was to, prior to the meeting, look up all the relevant articles, which turned out to be close to about 5,000, 6,000 articles on sleep duration. And then when we showed up at the meeting, then we sort of hashed it out what we felt was the appropriate amount of sleep for a healthy adult. And we came up with a number of 7 hours per night. And this was based, as I said, on the evidence, but also it was a consensus statement. There are some caveats, as you can see on this consensus statement on the second paragraph, as well as the third paragraph. But in general, most adults should sleep about 7 or more hours per night on a regular basis to promote optimal health. Now, one way that you can tell if you are getting enough sleep is to look this up on the web. It's called the Epworth Sleepiness Scale. The reason why it's called Epworth is that the creator of this, named Murray Johns, was from Epworth, Australia. And basically, it's a subjective scale to assess your level of daytime sleepiness. And you put down 0 for no chance of dozing, 1 for a slight chance of dozing, 2 for moderate chance of dozing, and a 3 for high chance of dozing for 8 of these situations. And what you do is you add it up, and if it's 10 or greater, then you are considered to have some subjective daytime sleepiness. And then you might consider, are you getting enough sleep at night? Or if you are, then you might consider, are you having a problem with the quality of your sleep, which is either due to medical or a sleep problem. Now, I'm going to switch gears and talk about obstructive sleep apnea, which is one of the key sleep-related breathing disorders. And it was actually written about as early as the time of Charles Dickens in his book, The Pickwick Papers, where he wrote, "And on the box sat a fat and red-faced boy in the state of somnolency." You can actually see him up here in the upper right-hand corner. Now, I always like to show this slide because it's a misconception in the sense that, people that have sleep apnea are overweight. About 30 to 67% of the people that have sleep apnea are overweight, as defined by a body mass index of 25 kilograms over a meter squared, but the rest are not. And certainly here in California, we see a lot of thin people that do have obstructive sleep apnea, and I'll go into the reasons why a little bit later. Now, one of the ways you can tell if you do have sleep apnea is you can take this just simple questionnaire and see if you have these symptoms. And it's called the Stop Bang questionnaire. It was actually developed by an anesthesiologist named Francis Chung in Toronto in 2008. And basically, if you have two or more of these symptoms that are listed there in the stop sign, namely loud disrupted snoring, daytime tiredness or sleepiness, observed or witnessed pauses in your breathing by your bed partner, or high blood pressure, if you have two or more of those symptoms, it's a good probability that you might have obstructive sleep apnea. This video shows a child that does have sleep apnea, and you can hear that the airway is partially occluded, so you can hear the gasping. And you can, right now, the airway is getting more and more crowded, so the child is trying to bring in a breath. You can see him struggling for breath, and eventually he'll have some capture breaths, or the breathing is restored to normal. But this can obviously go throughout the night, and it's not unusual for these children to wake up drenched in sweat and also have headaches due to the oxygen deprivation. And with children, we're also cognizant that they might not overtly manifest daytime sleepiness. They might be more characterizing obstructive sleep apnea as having attention deficit hyperactivity disorder-like symptoms, meaning that they might be moody, irritable, have difficulty focusing and concentrating throughout the day. So as opposed to adults that frequently will become tired and sleeping during the daytime, a lot of times children who have obstructive sleep apnea may manifest it through symptoms that very much mimic ADHD. So the prevalence of obstructive sleep apnea is about a quarter of adult men, 9% of adult women, and about 40% of of all patients in a primary care setting. Now, it's estimated that about 3% of children also have obstructive sleep apnea. And these are some of the predisposing factors. It does tend to show up around middle age. And I mentioned obesity as a risk factor, as well as male gender. Now, what's interesting is this is prior to menopause. So after a woman has menopause, what happens is the distribution or prevalence of obstructive sleep apnea becomes close to 1-to-1. But what we believe is that estrogen and progesterone somehow provide a protective effect of the upper airway and prevent it from collapsing until menopause. And then hypothyroidism, also medications such as benzodiazepines, which are things like Valium, Ativan, and also alcohol, can cause relaxation of the upper airway because what these medications and alcohol do is tend to relax the musculature, and because of that, it can relax the upper airway and make it more prone to collapse. And there's also anatomic abnormalities that I'll spend some time on in the next few slides. So one thing that we're always concerned about are the nose and obviously the upper airway, because it's estimated that approximately 5% of obstructive sleep apnea patients are estimated to be directly due to nasal obstruction, but it also has an indirect contribution to sleep apnea severity. Now, in that 5%, you pretty much have to have your nose almost completely occluded in order for it to directly cause sleep apnea. But if it's partially blocked, what can happen then is that it can cause redistribution of the airflow to the upper airway and make it more prone to collapse. And some of the things that we focus on when we do the exam in our patients is we look at the inferior turbinate to see if it's swollen and occluding part of the airway. We also look at the pharyngeal tonsil or the adenoids. Obviously, we can look at it in a physical exam, but if we suspect that, we'll refer to sleep surgery, where they can also do endoscopy to look at the adenoids. And then also, we pay attention to the tonsil as well. Now, the concept of nasal resistance in causing problems was noted even as early as 1887 when Dr. Guy connected large adenoids to apraxia, which is an inability to pay attention, poor memory, and headaches. And then by the early 1900s, there was this growing school hygiene movement in the United States. And a lot of people were convinced that enlarged adenoids were a common impediment to learning. So in 1905, New York City became one of the first cities to inspect students for enlarged adenoids along with ear, nose, and throat problems. And they actually started having adenotonsillectomies conducted during the daytime, within the school hours, for children that had been identified. And one thing that is kind of striking when you look at these early photographs is that what happens, and I'll go over this in the next couple of slides, is that when you have nasal obstruction, what happens is it, especially at an early age, it causes problems with the development of the upper and lower jaws, the maxilla and the mandible. And in turn, what happens is the height of the maxilla and mandible start increasing. And that causes the child, in addition to having a nasal obstruction, to become what's called an obligate mouth breather. So they rely a lot on breathing through their mouth. And because of the jaw changes, a lot of times they have what's called an open lip posture. And subsequent studies showed that this increased nasal resistance, as I mentioned, halted growth of the upper and lower jaws and induced changes in the nose, upper and lower jaws, and upper airway space. And as I was just saying, development of the mouth breathing in association with an increase in nasal resistance led to mouth opening and mouth breathing, not only at night while asleep, but during the daytime as well. And this obligate mouth breathing and alteration in craniofacial growth are associated with obstructive sleep apnea. And this is what I was mentioning earlier. So it does induce increase in height of the maxilla and mandible. And in addition, because of that, there's always this open lip posture that even at rest, the lips don't quite close. And so as a consequence, there's almost constant obligate mouth breathing in conjunction with the nasal obstruction. And this has been validated experimentally as well when they've looked at what's called cephalometric x-rays in individuals that are going to have surgery for sleep apnea. And what they find out is that the individuals have a mandible, a lower jaw that's pushed backwards posteriorly. So they tend to have a recessed chin. In addition, what happens is they have a greater inclination of the mandibular and occlusal plane, meaning that the height of the mandible is increased and a greater inclination of the upper incisor. So the front teeth tend to be splayed outward because also there is some increase in the height of the maxilla or upper jaw as well. So that aside, I also mentioned obesity is also a risk factor for obstructive sleep apnea. And in men, what has been shown is that if you have a neck circumference that's 17 inches or greater, there's a higher likelihood that you might develop obstructive sleep apnea. And the reason is this. So this is a control person, and this is a cut that's cut sort of parallel to the ground. And what you can see is that this dot is the airway in the center of the control. And then on either sides of the airway, there's what is called the lateral parapharyngeal fat pads. So there are fat pads that are on either side of the upper airway. Now, in a person that has obstructive sleep apnea that's due to obesity, I mentioned that what happens is if you have a high body mass index, oftentimes that will also translate to, especially in men, to increase in the lateral parapharyngeal fat pads within the neck. And then because of that, it puts pressure on the upper airway. So the upper airway gets compressed in a lateral dimension. And I also mentioned that because of anatomical abnormalities due to things like a recessed mandible or recessed lower jaw, what happens is if this lower jaw is pushed posteriorly, what happens then is the genioglossus, this large tongue muscle, gets also displaced backwards. And then what happens is especially when the person's on their back, gravity exerts also extra weight on the genioglossus and causes it to further collapse the upper airway. So what are some of the associations and consequences of obstructive sleep apnea? I mentioned that the key symptoms are habitual, loud, disruptive snoring, and then witness breathing pauses, as well as excessive daytime sleepiness. And you can see some of the outcomes and associations. It's very common for people with obstructive sleep apnea to have problems with daytime functioning, including daytime sleepiness, and as a result, motor vehicle crashes, psychosocial issues, as well as decreased cognitive function. Now, we do know that it does tend to affect three of the major domains of neurocognitive function, which are attention and vigilance, as well as learning and memory, as well as executive and frontal lobe function. So obstructive sleep apnea appears to affect, based on prior studies, affect all of those domains. It also impacts quality of life in terms of affecting their ability to function by the neurocognitive effects, as well as their daytime sleepiness. And it does have an impact on cardiovascular and cerebrovascular disease. Particularly, it increases the risk for high blood pressure, as well as coronary artery disease, increased chance of heart attacks, as well as congestive heart failure and stroke. And there does appear to be an association with diabetes and metabolic syndrome. And it does appear to affect mortality. So on the y-axis here, you have survival probability, and on the x-axis is years. And so what this slide shows is it shows people that do not have apnea, as well as those who do have apnea. So this dotted line are people that have what's called an apnea-hypopnea index less than 5. What that means is that they have less than 5 abnormal breathing events per hour of sleep, and that's considered normal. If it's 5 to 14.9, that's considered mild obstructive sleep apnea. 15 to 29.9 is considered moderate obstructive sleep apnea. Greater than 30 is considered severe. So you can see there's a corresponding increase going from those without apnea to mild, moderate, and severe. So there's decreased survival over the years, with increase in severity of obstructive sleep apnea. A lot of that is tied into cardiovascular risk factors and morbidity. So how do we diagnose it? Well, the way that we diagnose this is through a sleep study, and the 3 key measures that we look at are nasal oral airflow. We look at respiration of the chest, as well as oxygen saturation. And what you can see here is you can see an apnea, which is a complete pause in breathing, lasting at least 10 seconds and accompanied by at least a 3% drop in oxygen saturation. So you can see what happens is the airway collapses in the upper airway, and because of that, the person can't bring air into the person's lungs, and because of that, the oxygen falls. And this is despite the person trying to move the chest wall to bring in that oxygen, just as how you saw the child in the video. The child kept on trying to struggle to breathe, but because the airway was clamped down, the breathing couldn't be translated to bring air into the lungs. And this is an actual sleep study. So just to go over really quickly, the first 2 channels here are brainwave activity. The next one is chin muscle activity. Next 2 are right and left eye movements. This one is the left and right anterior tibialis. So this is a measure of the leg movements. This is EKG or electrocardiogram or heart rate. This is snoring microphone, oxygen saturation in the blood as obtained by a pulse oximeter that's attached to the finger. This is nasal airflow, oral airflow, oral pressure, and this is a chest wall movement, abdominal wall movement, and this is esophageal pressure. This is a small tube that's placed into the nose, into the esophagus that picks up transmitted intrathoracic pressure or pressure that's within the chest wall. So what you can see here, the individual is starting to have a pause in their breathing. So the airflow, both the nose and mouth becomes flat, despite the chest and the abdomen, trying to bring in a breath. And eventually it culminates in an arousal or awakening from sleep, and then it resumes again. So this pattern can, repeat sometimes 60 to 90 times per hour, where the person has a severe case of sleep apnea. Now, just to show you, how we kind of used to do things before COVID and how we're doing things after COVID. So before COVID, what would happen is we had an individual come in, for an office visit. We'd show them how to hook up equipment to their head and body to look at their breathing during their sleep. They would sleep with the equipment, bring it back the next day. We would download it manually to a computer and analyze the data, and then we would sterilize the equipment and repeat the cycle. Now what we're doing since COVID is we actually use this new technology where we can actually mail this device to the person's home. And it basically consists of a wristwatch-like device that they wear on their wrist, a finger cuff that goes over their index finger, and an electrode that goes on their neck. And then what they do is they download an app to their smartphone. And then what happens is that they just push a button on the smartphone app when they go to bed. When they wake up, they push another button on the app. Then the data immediately gets uploaded to the cloud, and then they can just dispose of the device. So it's an ideal situation for actually detecting people that do have sleep apnea at home. We can also do in-laboratory sleep studies, and what we're doing is, fortunately, within our laboratory space, we have a special air handling system that brings in outside air through extensive filtration. And then what happens within 6 minutes, all that air gets pushed out of the bedroom. So there's hardly any recirculation of air, and it's ideally suited, for the pandemic because there's not too much exposure to airborne pathogens. So what are the treatments for snoring and obstructive sleep apnea? The big three are positive airway pressure, surgery, and oral appliances. These other ones, don't really work that well. And behavior modification is just a fancy way of just saying that we try to encourage people to sleep on their sides and also maybe elevate their head of the bed 30 degrees. But as I said, none of these really work that well. CPAP is the most common and effective treatment for obstructive sleep apnea. And what this slide shows is it shows a 24-hour cycle where this first part is being awake, the second part is being asleep. And this was a study looking at 59 subjects, research subjects, and half of them were randomized to active CPAP. The other half were randomized to sham CPAP, which looks and sounds like a CPAP device, but instead of pushing air into the nose and down the throat to prevent the airway from collapsing, it actually delivers only 0.5 centimeters of water pressure compared to the usual 7 to 15 centimeters of water pressure. So it's considered subtherapeutic CPAP. And so this was a baseline condition, and this is mean arterial pressure. And what you can see is that during the night, in most people, there's a decrease in blood pressure compared to the daytime. But what happened is when the patients were placed on CPAP, the ones with therapeutic CPAP decreased their blood pressure. But you notice the blood pressure didn't decrease only at night, but also during the daytime. So even if patients wear the CPAP device as they're supposed to just at night, when they're asleep, it still has an impact on their daytime blood pressure as well. But the big problem with CPAP is adherence, and this was one of the studies that I did looking at over 1,000 patients to see, what their adherence was. And what you can see is that most dense usage is between 300 and 500 minutes per night. So even though this was a well-controlled research study, meaning that we kept very close monitoring of our patients, more so than we would normally do in the clinical setting, we couldn't really have that much of a big effect on increasing adherence of the uses of the device. And you can see that 29 to 83% of patients are estimated to be non-adherent to CPAP using a metric of a pretty low bar of 4 hours per night. And these are oral appliances. This shows one of the oral appliances. It basically it fits on the upper teeth and on the lower teeth. And it either has hinges or tabs, which prevent the lower jaw from being pushed backwards. But you can open up your mouth, you can move it from side to side. It just prevents the lower jaw from being pushed backwards. Now, because it's much less cumbersome than a CPAP device, you can see that in terms of convenience, patient partner, bed partner acceptance, tolerance, and adherence, compared to CPAP, which is this. The oral appliances were much better. Where the oral appliance falls short compared to CPAP is with effectiveness. It's not as effective as CPAP. And the reason is, if you look over here, what happens is, this is the lower jaw. And if you move the lower jaw forward, you can increase the space behind the lower jaw. But the airway collapse can be anywhere from the free edge of the nasal septum all the way down to the vocal cords. So if the site of collapse is other than the base of the tongue, you're still going to have a little bit of sleep apnea. That's why CPAP works so well, because no matter where the obstruction is, it's going to open it up by that moving column there. But oral appliances, just tend to work at that base of the tongue. That's why it's less effective than CPAP. Upper airway surgery can also be very effective for obstructive sleep apnea. This is a procedure called maxillomandibular advancement, where they actually are able to surgically move the jaws forward. And you can see this is the posterior airway space pre-surgery, and this is after surgery. So you can see that there was significant enlargement of the upper airway. And these just show some of the other things that have been tried and are in current use right now. There's nasal stents to actually prop open the nose as well as the upper part of the airway. There's also this thing called DOME, which stands for distraction osteogenesis with maxillary expansion. So it's basically expanding the upper jaws laterally to open up the airway. This is another procedure called hypoglossal nerve stimulation, where they implant a small cuff around the hypoglossal nerve that innervates the tongue muscle. And there's a pacemaker-like device that's underneath the chest wall cavity that detects the breathing cycle. And then what happens is it gives a small electric shock to the tongue, which causes it to move forward and open up the airway. These are palatal stiffeners, meaning that there's ways of injecting either devices or fillers to increase the stiffness of the soft palate to prevent it from collapsing, and also things like transcranial magnetic stimulation have also been tried. But currently, as I mentioned, the main treatments are CPAP, positive airway pressure, oral appliances, and upper airway surgery. And just to show what we're doing right now, what we're trying to do obviously is trying to make obviously better or optimal care for our patients. And the way we're doing it is we're trying to leverage a lot of the new technology, especially since we're so close to Silicon Valley, and a lot of it is focusing on new treatments, but as well as using artificial intelligence as well as machine learning to score our in-laboratory as well as home sleep studies better to minimize the reliance that we have on manual scoring and review of our sleep studies. And also we're also trying to use wrist-borne devices as well as devices that go underneath the mattress to also help to estimate sleep as well as help to diagnose sleep disorders. So now I want to shift over to another common sleep disorder, which is chronic insomnia. And as you can see, there's many different contributors to insomnia, anything from poor sleep habits to psychiatric conditions, medical conditions, acute stressors, circadian rhythm disorders, or variations in the sleep-wake cycle. Medications play a role as well as other sleep disorders. So the key insomnia symptoms are an inability to fall or stay asleep when desired. And there's actually a condition arousal to the bedroom environment or sleep-related activities. What that means is that as bedtime nears, the person tends to get more and more agitated and have difficulty calming down to bedtime and just feels more alert. And there's increased somatized tension at bedtime, meaning that the body tends to feel more tense, physically tense near bedtime. And generally, if the person has difficulty falling asleep within 30 minutes, repeatedly, that could be a sign, as well as frequent awakenings at night and not being able to fall back asleep. Those are key symptoms of insomnia. And these are some of the associated symptoms that you can have. You can see it's pretty much a laundry list of symptoms that are very common. But these are things that we also look for when we're evaluating a person with chronic insomnia. And there's two major common types of insomnia. One is called psychophysiological insomnia, which you see here is a disorder of somatized tension and learned sleep-preventing associations. Now, the way we think of this is typically what happens is the person might be an okay sleeper, but then they might have an event that might have occurred, say, like a loss of a job, a divorce, anything like that, or even like a sickness in the family. And then what happens is that if that insomnia at that point isn't corrected quickly, it can develop into a chronic insomnia. And what happens is even if the initiating event that caused the insomnia has improved, like say they got a better job, entered in a new relationship, so the initial event that triggered the insomnia was remedied, but they still have the insomnia. That's why we think it's a psychophysiological effect, that it was the behavior altered the physiology, so it was a biobehavioral event that actually caused somehow either an alteration in the neurotransmitters or an alteration in the neurons. And none of this, obviously, we can prove, but that's what we suspect. Idiopathic insomnia, we definitely think is a neurologic issue where, almost practically from birth, the patient says they've never been able to sleep well. So one of the things that we do is we have the patient fill out a daily sleep diary, or we use actigraphy, which is a wristwatch-like device that they wear that detects motion and gives an estimation of sleep-wake cycles. But we really don't use our sleep studies, if we suspect insomnia, because the data that we get from the sleep study is pretty much what you would expect. Namely, we see a very light sleep. We don't see much deep sleep, and we see a lot of awakenings during the night, as well as it takes the person a long time to fall asleep. So in terms of treatment, behavioral techniques are used first, and I'll go into those. Occasional mild hypnotic may be used, and psychological or psychiatric counseling may be useful, especially if the person has a concomitant depression or anxiety disorders. And here are some common over-the-counter agents. You can see that what's a little problematic is not only do these agents take a long time to take effect, but also the half-life can be prolonged. And especially in elderly individuals that have a hard time metabolizing the medications, you can see that those that were exposed to diphenhydramine, which is the active ingredient of things like Benadryl, compared to those that weren't, there's a greater tendency for them to have things like inattention, disorganized speech, altered consciousness, and even approaching things like delirium. I do want to say a little bit of melatonin. Melatonin is a substance that's secreted by the pineal gland, and it's maximal when we sleep at night. It is inhibited by light, and it may phase advance the major sleep period, meaning that it may cause a person to fall asleep earlier rather than later, which is beneficial for a person that has chronic insomnia, as well as a circadian sleep disorder that causes them to want to sleep later. And its highest level occurs in children, but then it falls during puberty and further during adulthood. Antidepressants, trazodone is still one of the most commonly prescribed medications for the treatment of insomnia. And you can see other things like doxepin can also have beneficial effects on sleep. But we tend not to prescribe too many antidepressants unless the patient also has depression or dysthymia, because we're actually relying on the side effect of side effect of sleepiness of the antidepressant as being the treatment for insomnia, which isn't a good thing. So we only tend to I think about prescribing it if the person has concomitant depression or bipolar disorder. Benzodiazepines are things, as I mentioned, things like Valium and Ativan. They can be effective in short-term insomnia management, but you can see they cause a lot of side effects or adverse events. These are the most common benzodiazepine receptor agonists that are used. A lot of times our primary care physicians as well as we'll use it a lot of times for acute insomnia. And isobucolone is Lunesta, Zaloplan is Sonata, Zolpidem is Ambien. And you can see why it can be effective. It has fairly quick action, and the half-life in most cases are shorter. In the case of Lunesta and Ambien CR, they're mainly used for patients that have difficulty staying asleep, as opposed to Ambien and Sonata, which are used for mainly initiation insomnia or people that have difficulty falling asleep. And these show some of the newer medications. One is Ranellition, which is also called Rosarum, Suvorexant, which is Belsomra, and Lemborexant, which is Divigo, which has just been approved in February by the FDA. And these last two are orexin antagonists, so it's a different mechanism for treatment of insomnia. So the way this was originally conceived is people that have narcolepsy, they tend to have a deficiency in orexin, and that can result in the daytime sleepiness. So with an orexin antagonist, that would tend to make people a little more sleepier at night. But there are potential adverse events for any of these medications. And that's why for chronic insomnia, besides the key things that dependence and tolerance, there's a lot of side effects with these medications. That's why what we tend to use is cognitive behavioral therapy for insomnia. This behavioral treatment is the only thing that tends to work long-term on people that have chronic insomnia. And it consists of these various types of treatment. And I'll go over some of them right now. But one that people always tend to associate with CBTI is sleep hygiene or sleep habits, but that's not really the main thing. As you can see, there's many different types of treatments, but nevertheless, we always try to encourage people to have good sleep habits because that's important in improving their sleep. So one is relaxation therapy, and it can improve up to 72% for non-medicated patients with insomnia. And it consists of progressive muscle relaxation, which you might have heard the tapes where in a calming voice someone says to tense and relax your thumb, then tense and relax your hand, tense and relax your arm, and so forth. So that's progressive muscle relaxation. It can decrease your wake time by about 20 to 30 minutes. Also included in this is meditation, self-hypnosis, and biofeedback. There's also sleep restriction, where you basically try to advance the bedtime. So you keep the awakening time the same, but over the course of weeks, you tell the person to sleep a little later each week. And then what happens is, because you do that, you make the sleep more efficient. So you reduce the wake after sleep onset by 54% and improve the sleep efficiency, which is the time spent asleep over the time in bed, by almost a quarter. And then there's temporal and stimulus control techniques, which are just standardize the awakening time, avoid daytime naps, turning off the light immediately upon retiring, avoid reading or watching television, eating or working in bed unless they make you drowsy. And then if you can't fall asleep or can't fall back asleep upon awakening within 20 minutes, you should actually get up out of bed, go to another room, do something that makes you drowsy, then go back to bed, because that is a stimulus control technique that it reconditions the bedroom environment being a place to sleep and not for tossing and turning. There's also cognitive therapy, which is to modify these harmful thoughts that interfere with sleep through worry, effort, and control. And you also try to challenge avoidance behaviors such as calling in sick at work. Also, something that's very important is circadian sleep disorder phototherapy, which means that you have bright light in the morning. Now, what that means is within 5 minutes of getting up, expose yourself to about 30 minutes of bright light, because that will essentially put a timestamp on your brain and make it easier for you to go to bed at night. At the same time, you should avoid any bright light in the evening within a 3-hour window, because that if you get some bright light, that can delay your onset of sleep. And the light intensity that's recommended is 2,000 lux for 30 to 45 minutes. And most commercial light boxes that you can get for the treatment of seasonal affective disorder, they definitely fit within that range. And if you just go outside, you'll get thousands and thousands of lux just through sunlight. And morning light should be administered, as I said, within 5 minutes after waking up for about 30 minutes. So I just want to conclude with some do's and don'ts. So do maintain regular bedtimes and waking times. Try to optimize your sleep amounts. Try to get at least 7 hours per night. Try to use a bright light in the morning. Try to select an optimal environment to make sleep really conducive. And then establish a regular pattern of relaxing behavior within an hour before bedtime. Some people do light stretching or yoga or meditation, things like that. And then exercise on a regular basis. What that means is don't exercise within 2 hours of bedtime, because that can actually cause your neurotransmitters and other hormones to become activated and make it difficult for you to fall asleep. Don't take a nap unless you're about to get behind a wheel of a car, or if you take a nap every day at the same time for the same amount of time and your body gets used to it, that's fine. But if you take irregular spontaneous naps, it can throw off your nighttime schedule. You should avoid eating or drinking heavily before bedtime. You should set a cutoff, as I mentioned, of 20 minutes, and you shouldn't just constantly look at the watch. You should estimate the 20 minutes to fall asleep and to pull back asleep. And if you can't do that, you should get up and, as I said, go to another room, do something that makes you drowsy, and you go back to bed. You should avoid disturbances and, as I mentioned, reading or watching television in bed unless they make you drowsy. And the last one is pretty obvious: alcohol, caffeine, or nicotine. Caffeine and nicotine are stimulants. And alcohol can help to make you fall asleep, but it cuts down the amount of deep sleep, as well as it fragments your sleep. And as I mentioned, if you have even a predisposition for obstructive sleep apnea, it can actually make it worse. And I just want to show the slide. These are some of the research studies that we're currently doing at Stanford, and we are interested in recruiting participants. So if you have any of these disorders or are interested in the studies, you can just reach out to us. And I'm happy to open things up for questions now.
Great. Thank you, Dr. Kushida. So much useful information in this. And we have some questions, and we'll try to move through them. A couple of questions on pillows. And have there been any pillows tested that you can recommend?
Yes. So, what's interesting is we've actually done some pillow studies in our lab because sometimes manufacturers will want us to evaluate pillows. And the ones that we've evaluated are mainly the ones that tend to elevate the chin. So they tend to support the neck by pushing the chin upward. And what's been interesting is when we've tested them, they've actually shown improvement in snoring as well as mild sleep apnea. But that's only if they can elevate the neck. In terms of comfort for pillows, we get a lot of those questions as well as mattresses, and really the only way to test it is just to align it for an extended period of time. And what you for mattresses and pillows, what you want to do is most people should try to, not everyone, but most people should try to lie on their back, especially if they have a tendency for obstructive sleep apnea. And when you lie on your back, when you're on the mattress, you can have someone look at the long axis of your spine and your neck to make sure that it's parallel to the ground. Because if it's not, that can mean that your mattress and your pillow are either too firm or too soft, and that can throw your back and your neck out of alignment, which in turn can maybe lead to peripheral neuropathies or other issues. So that's the only thing that I would recommend in terms of medical connections to mattresses and pillows. The rest is all just personal preference in terms of comfort.
Okay, this is not unrelated, but question about a Sleep Number bed and Garmin sleep apps that measure our sleep every night. And is this data meaningful? And if so, why? Because we have lots of those technologies now.
Yeah, so at the present time, the technologies that rely on movement, as well as things like heart rate variability and things like post-transit time and other measures, they're not quite there at measuring sleep accurately. In fact, it can be about an hour or more off in terms of total sleep time. And in terms of detecting light sleep versus deep sleep, it's also very problematic right now because, and I think that's why they call it light sleep and deep sleep in most cases, because it doesn't really align that well to the stages that I was talking about earlier, N1, N2, N3, and REM. It's the technology right now isn't at that point, but in about 5 to 10 years, it will be. And the way I know that is that my lab also does testing for a lot of these devices, just because we're close to the Silicon Valley. And what's interesting is by the time we finish testing one prototype, oftentimes the companies will have the next prototype. So that shows how quickly they're doing these improvement cycles. So eventually, I think within 5 or 10 years, they'll be able to really detect sleep pretty well, and it might even be sooner than that.
Great. Dr. Kushida, you shared a slide at the beginning with the ideal hours of REM and deep sleep, but we have a question asking, what are the ideal amount of time for REM, deep sleep, and light sleep?
Yeah, so the thing is, it tends to vary, as I showed in that graph, and I can just quickly go back to that. So you can see here that with age, it decreases over time, and there's a lot of individual to individual variation, but in most cases, what you want to see is like it's showing over here, REM sleep about 20% of total sleep time. Now, if you have like 5 or 10% or 30%, it really doesn't make that much of a difference, because there is night-to-night variability in the amount of REM sleep as well as non-REM sleep. We only get concerned if there isn't any REM sleep or very little deep sleep. So in answer to your question, in general, it should be about 20% of total sleep time should be REM sleep. And in terms of the other stages of sleep, it can be about 10 to 20% of N3 sleep. Majority of sleep is in the range of N2 sleep, which can be anywhere from like 20 to 50% of total sleep time, and N1 sleep is like 10 to 20% of sleep. So by far the most sleep that you'll see is N2 sleep, and N3 and REM sleep, as well as N1 sleep are less than that.
Great. Here's one. Today we had Martha Stewart on the cover of the New York Times talking about her CBD products for sleep. And the question is, do you know if the CBD oil impacts sleep or insomnia? And then its sister question, does THC disrupt or assist with sleep?
Yeah, so, right now there's still a lot of work that needs to be done in terms of evaluating the effects of CBD on sleep. We do know that it does change the sleep architecture. Just like alcohol, it does make the person fall asleep quicker. But in terms of increased sleep as well as REM sleep, it does tend to have some decrease in that. So that's what's a little bit concerning. But the problem is there just isn't enough well-controlled studies to look at the sleep architecture and to see what the impact of CBD is on sleep as well as daytime alertness and sleepiness.
And would that be true for THC as well?
Yes.
Okay, great. And here's a question: for recovering from sleep debt, is it better to go to bed early or sleep in?
Oh, it's always better to go to bed earlier because in terms of sleep hygiene or sleep habits, it's always best to fix your morning awakening time and to adjust your time that you go to bed. So if you're sleep deprived, and obviously, one thing that you should always try to do is try to keep a regular sleep wake schedule. But if you're in a situation where you do need to forgo sleep on some nights, then what you need to do is you should still fix your morning awakening time, but sleep earlier. It's okay to take naps in those situations as well, but I wouldn't take more than a 20-minute nap. And the reason is that if you take more than a 20-minute nap, what happens is then you start to get into deeper stages of sleep, and then it leads to a thing called sleep inertia, which is because you're waking in deep sleep. What happens is that you'll be really foggy, and your neurocognitive abilities will be impaired for a short period of time. So it's better to take a short nap if you're in a situation where you're sleep deprived.
Now, here's a question: can a sleep study diagnose anything apart from sleep apnea?
Oh, yeah, absolutely. So the home sleep test is mainly used for assisting in the diagnosis of sleep apnea. But for the in-lab sleep study, that can help you diagnose most of the sleep disorders, because we put electrodes not only on the head, but also on the body to detect things like movements of the chin, leg muscles, arm muscles. We also look at the heart rate as well as a breathing. So, there's 6 major categories of sleep disorders, and with the sleep in sleep study, we can diagnose the sleep-related breathing disorders, sleep-related movement disorders, parasomnias, which are unusual behaviors that occur during sleep. But what's difficult is with the insomnia, as I mentioned, because that pretty much shows what the person reports anyway. So insomnia we can diagnose just by talking with the patient, as well as circadian sleep disorders. And the last one is hypersomnias or narcolepsy, and that one also we can diagnose by a nighttime sleep study combined with the daytime test that I mentioned earlier, the multiple sleep latency test.
Great. We have time for one last question. What does it mean if you have low latency to REM sleep and, for example, you dream during a 10-minute nap?
Yeah, so what happens if you, by low latency, what that means is you're going into REM sleep less than 20 minutes. So, when you go to sleep, and then within 20 minutes, you actually have REM sleep. That's a low sleep latency or a short REM latency, because the REM latency is measured from the time that you fall asleep to the time that you go into REM. So if it's less than 20 minutes, it's considered low REM latency. And then you might consider, is the person sleep deprived, or might the person have a narcolepsy, because that is one of the things to consider. And then the other question was, if you take a nap Could you repeat that again? If you take a 10-minute nap, and what happens
If you have low latency to REM sleep and then you dream during the 10-minute nap.
Okay. Yeah. Well, if you dream during like a nap that isn't being recorded in a sleep lab, but you have a dream in a nap, I mentioned that 90% or more of the dreams occur in REM sleep. So it is possible that you might have a short, REM latency, when you take that 10-minute nap. It could also mean that, as I said, that you could be sleep deprived, because that would make your REM period appear earlier. But the other thing is that even though 90% of the dreams occur in REM sleep, the other 10% occur in other stages of sleep. So it could just mean that you were awake when you woke up after 10 minutes, you were just in the middle of a dream that occurred in a non-REM sleep period.
Great. Well, thank you, Dr. Kushida. That's taking us right to the end of the hour. And I just want to thank you for your generosity in speaking tonight and sharing all this information with us. For our viewers who are watching this, if you want to watch it again, it will be up on the Stanford YouTube channel within the next week or so. And if you have further questions about sleep and sleep disorders beyond what Dr. Kushida talked about, or you're interested in resources, please contact us at the Stanford Health Library. Our medical librarians are happy to do research for you. Everything we send you will be scientifically based, and it's very often from materials that you can't receive or find on the free internet. So that's a free service that's available from the Health Library, and we like to offer it at the end of these talks because sometimes there are other questions. Thank you again for joining us. And Dr. Kushida, thank you very much for a really inspiring, interesting talk. Have a good night.
Thank you.
Night, everyone.